Hello friends, today we are going to discuss about treatment-resistant depression. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about treatment-resistant depression, specifically focusing on major depressive disorder. I will not be discussing about bipolar depression. I'll be discussing about prevalence of treatment-resistant depression, what are the definition of treatment-resistant depression, factors influencing treatment resistant depression, and finally, what are the assessment you have to do in treatment resistant depression. If you look at the prevalence of depression in general, 20% of the population do suffer from depression. This is as per a study done by Hassin and colleagues and published in JAMA Psychiatry. Similarly, the National Comorbidity Survey, which was published in 2003, reported 16% of the US population do suffer from depression. Study done in India, a National Mental Health Survey, reported 5.3% have lifetime depression. You need to know depression is a chronic, waxing and waning disorder which causes relapse, recurrence, remission, and the timing of this onset, occurrence, remission, relapse is very difficult to time it. Above all, we do not have any lab test to diagnose depression. The diagnosis of depression is completely based on clinical examination by a psychiatrist. Further, depression is associated with disability. In the past 2 decades, the depression disability has increased up to 53%, and it is now the second leading cause of disability in the world. The disability is due to loss of employment, economic burden, functional impairment, marital discord, including family discord, time spent in the hospital, morbidity, and mortality due to suicide. Unfortunately, the patients who are suffering from chronic medical conditions such as chronic renal failure, arthritis, cancer, psoriasis, and various other medical conditions, they do have comorbid depression. They are not being diagnosed or treated. That means they are suffering from not only with the chronic medical condition, but also depression. Along this, the stressors which are occurring in the life, it may be economical stressors, job stressor, family related stressor, interpersonal related stressors, disability, family member suffering from medical condition. That means you are the caregiver. Entry exit stressors. Entry means birth of the child. You have been promoted and you have been shifted to a new place, or else exit events, somebody's death or relationship breakdown. In such a scenario, stress is well known to occur, along with this depression. Now let's discuss about specifically treatment-resistant depression. Treatment-resistant depression, if you look at that, 60% of the patients who have been diagnosed to be suffering from depression do not respond to adequate trial of antidepressant. A third of the patient do not improve even with multiple sequential trial of antidepressant. One third of the patient achieve remission. That means complete improvement, only one third. That means we are going to see one third of the patients who do not improve, another one third will have partial improvement, one third will have remission. If you look at the response to sequential trial, whenever you give the first trial of antidepressant, only 22% get remitted. If the second addition of the antidepressant will improve by another 23.5%. Third is 20%. The endpoint is 50% only. The non-response will go up to one third, that is a 30%. A sequential trial by the treatment alternative relief depression, that is TRD, the cumulative remission rate of 4 trials of antidepressant was 67%. That means 33% continue to have treatment resistance. Clearly, the various studies also have said 30% do not respond to 4 trials of antidepressant. Most clinicians use trial and error method to choose SSRI based upon the comorbidity, age of onset, presenting symptoms, and also if it is a agitated depression or a retarded depression, and also the medication side effect profile will be used. Hence, there is no specific rigid treatment guideline to tell that you have to give this medicine and the next medicine, because the patients will have comorbidity, their symptoms, their affordability, at the same time, the medication side effect, and also any presence of comorbid psychiatric or medical condition will dictate the medication. Hence, we may not have a rigid algorithm which you say you have to give the first medicine and second medicine will be this. That is not possible in psychiatry. Further, it has been estimated one third to two-third patient adequately treated for major depressive disorder did not respond for the first antidepressant. Further, one third do not respond to any kind of sequential trial of antidepressant. That means it is a major challenge for any psychiatrist who is treating the patient. Considering this, considering the remission, 60 to 70% of the patient with a major depressive disorder experience residual symptoms after treatment. That means they will have difficulty in concentration, they may have poor energy level, they may not be able to have a good memory, and also various occupational dysfunction. They may have a symptomatic recovery, but the functional recovery may not happen, as well as the relapse do occur, and the recurrence rates are also well known in major depressive disorder. If you look at the treatment resistant depression, it is a debilitating chronic medical condition. It causes increased morbidity and mortality. It decreases the quality of life. Many patients may start using drugs, alcohol. It impairs occupational, social, and also the looking after the children becomes very difficult. They will not be able to fulfill the obligation of the marriage breakdown, and all this translates into increased cost of healthcare in the society. Depression causes a huge burden not only on the patient, on the family, on the community, and the nation at large. That means a huge burden and the huge economic loss is expected on the nation. Let's define treatment resistant depression. There was a study by Gaines and his colleagues in 2019, and it was published in Depression Anxiety Journal. The title of the study was Defining Treatment Resistant Depression. This was a review in which they clearly came out and said that there is no consensus with regard to definition of treatment resistant depression, especially in major depressive disorder. This definition dilemma, and also there is no consensus in the definition, has met with a severe challenge with regard to developing guidelines, doing research, what is treatment resistant depression, how to go about developing a treatment algorithm becomes a big problem in the treatment resistant depression. Now let's understand what are the challenges in defining treatment resistant depression. First and then foremost, many studies do not agree upon what is the number of antidepressant should be considered to say treatment resistant depression. The Gaines study said that many studies, approximately 9 studies said that one antidepressant failure means it is considered a treatment resistant depression. Only 68 studies considered two antidepressant given in adequate dose and duration can be considered as adequate trial. Only 9 studies considered only 3 antidepressants. So if you look at this, the maximum study focused on one antidepressant followed by two antidepressants. That means there is no consensus how many number of antidepressants given in adequate dose and duration should be considered as adequate trial. The next one is adequate duration. Again, there is no consensus whether the medication should be given for 4 weeks, 6 weeks, 8 weeks, or 12 weeks. If you look at the response rate, when the medicine is given, especially SSRIs, selective serotonin reuptake inhibitors. Within 2 weeks of starting the adequate dosage, 36% of the patient respond. At the end of 4 weeks, further 18.9% respond. At week 6, only further 6.5. That means the 4 weeks can be considered as adequate trial. Unfortunately, many studies did not take this adequate duration, and there is no consensus again. Some studies looked only 2 weeks, some study looked into 3 weeks, some of them looked into 4 weeks, and some study looked into 8 weeks. Hence, the comparison between these studies becomes a big headache. The next comes is dosage. Especially in depression, what should be the adequate dosage? What is the minimum adequate dosage and what is the optimal dosage? If you look at the fluoxetine, 20 mg is considered as the minimal adequate dosage and 40 mg is the optimal dosage. Again, there has been various studies considering various medication dosage becomes again a difficult proposition to compare these studies and say, yes, this study has a robust methodological issues. That means it can be considered for meta-analysis. The next biggest challenge is, should we consider psychotherapy as one of the criteria to say it is treatment-resistant depression? Many of the, if you look at the guidelines, do not consider psychotherapy as one of the criteria for treatment resistance. The simple reason is, what is that psychotherapy? Which type of psychotherapy? Is it CBT? Is it interpersonal therapy? Is it psychodynamic psychotherapy? Is it dialectical behavioral therapy? Is it only behavioral therapy? Is it hypnotherapy? So there are many therapies. Hence, it becomes very difficult to know which psychotherapy was considered, how many number of sessions, how many sessions in a week or a month, what was the treatment fidelity, how the psychotherapist gave the therapy. That means the patient may not receive same kind of therapy across study. Hence, it becomes very difficult to compare. Further, manual psychotherapy has been brought in now. But again, with psychotherapy and across other studies, it becomes difficult. But further, there is no pharma funding here. Hence, psychotherapy has been kept out of treatment-resistant depression definition for simple reason is difficult to materialize, and many a time it is access to treatment-resistant depression becomes a big challenge. If you do not have access to psychotherapy and you are not affordable for psychotherapy, that means you will not be termed as treatment resistant depression. No aggressive management will be considered. And in many countries, psychotherapy waiting period is just 1 year. That means after 1 year, you will be undergoing therapy. Till then, should we consider as treatment resistance or else wait for another 1 year till the psychotherapy is available? Then only we will consider treatment resistant depression. So these are the biggest challenge. The next challenge is, should we consider neuromodulation such as ECT, RTMS, deep brain stimulation, vagus nerve stimulation? Should we consider them? Again, many of the researchers have raised concern. Access to this therapy, neuromodulation therapy, is not uniformly present. Again, the site of stimulus, parameter, dosage, number of sessions, and number of setting is varying across the research. And further, many of them pragmatically said that when there is no access to this treatment, please don't make them in the treatment guideline. Hence, neuromodulation does not figure in majority of the algorithms or else treatment guidelines or else in definition of treatment-resistant depression. Above all this, how to define response? Many studies have said that if the patient improves just 50%, consider them they are respond. What will happen if the patient has improved only 52%? The study said you consider them as respond. That means he continues to have 48%, but he will be considered as respond. We are not taking 100% response as a response. Again, defining partial response, remission, and relapse becomes the biggest challenge. How long the duration of follow-up should occur? When should we consider as a relapse? When should we consider as recurrence? Defining residual symptoms. If there is a comorbid medical illness, should be considered in the study or not? Which scales to be used for the assessment and effectiveness of treatment? Should we focus on functional outcome or the clinical outcome? This is another biggest challenge. And of course, placebo effect and nocebo effect further challenges the researcher. However, studies recently have said that treatment response is defined as a reduction of 50% in depressive severity on a standardized rating scale. Partial response are those who improve between 25 to 50%. Treatment resistance clearly means if the patient does not improve more than 25% on a standardized rating scale, so then it is considered as treatment resistance. Now let's look into categorical versus staging of definition in treatment resistance. Categorical means there are two antidepressant failure, whereas staging is stage 1, stage 2. That means it's a dimensional approach. Dimensional staging approach versus categorical clear-cut definition. If you look at the first one was Thays and Rush, who defined with staging model. In their stage 1, they said that if there is one antidepressant failure, inadequate dose and duration, stage 2, failure of an additional antidepressant in a different class is considered as stage 2. Stage 3, failure of tricyclic antidepressant. Stage 4, monoamino oxidase failure. And stage 5 is failure to respond to ECT. This staging gives you the severity and also understanding becomes easy. Similar to that, the dimensional approach taken by Massachusetts General Hospital staging model for treatment-resistant depression. This gives a point for every step. 0.5 points is given if there is no response following dose optimization, no response for augmentation, if there is no response for combination. Whenever this is done and the patient does not respond, 0.5 is given to the patient. If there is no response for an adequate trial of one antidepressant, 1 point is given. If the patient does not respond to the second, 1 more point is given. If the patient does not respond for 4 antidepressants, that means 4 points will be given. If the patient does not respond to an ECT, 3 points is given. More the point, more severe treatment resistance it is. So, this model appears to be very attractive and also it predicts the treatment outcome to some extent. This dimensional and severity approach can be used for disability certification and also considering whether we can choose novel treatment like vagus nerve stimulation to be considered. Another important Maudsley staging model has been developed. Based upon the duration, the score will be given. If it is an acute 1, if it is chronic 3 is given. Symptom severity, again, mild means 2, moderate 3, severe without psychosis 4, severe with psychosis 5. Antidepressants, level 1, 1 point is given when 1 to 2 medications are failed. Level 2 means 3 to 4 medications are failed. That means based upon various parameters, the scores are given. And if the score, maximum score will be 15, and if the patient more nearer to the 15, that means he is severely treatment resistant. And if he reaches 15, it can be considered as treatment refractory depression. Another important staging came is Dutch measure for quantification of treatment resistance in depression. It is considered as TRD. Herein, Dutch measure also takes into various factors for scoring: episode duration, symptom severity, functional impairment. And these, based upon the severity, the scores are given. If there is comorbid anxiety, if there is comorbid personality, psychosocial stressors, treatment failures, number of medications failed based upon the score is given, augmentation and again combination. The points are given. If the electroconvulsive therapy is given, any other psychotherapy is given, is it inpatient or outpatient? Based upon this, the score is given. Here, the maximum score is 27. And hence, again, my dear friends, the Dutch measure for quantification of treatment resistant in depression is being considered for various trials. Now, moving further, there was an important Delphi method consensus guideline for definition of treatment resistant for depression for clinical trial was published. This was published by Luca Safrozoni colleagues in molecular psychiatry. Here, they found that if the treatment resistant is considered typically refers to inadequate symptom improvement following one antidepressant trial. And this study also discouraged just one antidepressant should not be considered. However, it said that many studies considered minimum of 2 prior adequate trial of antidepressant and failure to respond. So, there were either one medication or 2 medication. Invariably, it should be considered as 2 medications. Further, the more rigorous definition was brought by Multi-European Research Contribution Consortium. It is group for the study of resistant depression. It considered at least 2 adequate trial of antidepressant. Either it can be consecutive or as a combination or an augmentation therapy. That means 2 antidepressant has been failed either by combination, switching or augmentation. The patient should continue to have moderate to severe symptoms of depression. Now, this is how the definition of depression is considered. Now, let's look into what are those factors contributing for treatment-resistant depression, or else you can consider as predictors for treatment-resistant depression. It can be considered as clinical factors. If the more the severe the symptom, there is a possibility he may not respond. Longer duration of illness, psychotic symptoms, suicide risk, generalized anxiety disorder, inpatient, high number of antidepressants has been given and he has failed to respond, lifetime number of episodes, more the episode, that means there is high possibility he will become treatment resistant, and also here the duration of current episode, the more the duration, the possibility he may not respond. Comorbid psychiatric illness like anxiety disorder, OCD, personality disorder, borderline personality disorder, substance use, OCD, all these again adds to the resistance. Further, chronic neurological condition such as multi-infarct dementia, epilepsy, chronic autoimmune conditions, post-infective sequelae, post-head injury sequelae, and various other neurological conditions can cause treatment-resistant depression. Further, many of the medical conditions can also cause, such as endocrinological, hypothyroidism, Cushing's, Addison, fibromyalgia, chronic fatigue syndrome. Sleep disorders has been considered as one of the important indicator for treatment-resistant depression. If the patient reports of severe insomnia, there is high possibility he may not respond. Chronic pain disorder, irritable bowel syndrome, using various other drugs, calcium channel blockers, vitamin deficiency can add for treatment-resistant depression. Further, the patient who is on chronic corticosteroids, interleukins, and interferons can also cause treatment-resistant depression. Chronic medical conditions such as renal failure, cancer, diabetes, hypertension, arthritis, psoriasis, all these can contribute to treatment-resistant depression. There has one of the important study by Connor and his colleagues, which was published in Journal of Clinical Psychiatry. The title of the study was Predictors and Risk Factors for Treatment-Resistant Depression. This was a systematic review and it was published recently in 2024. If you look at the various predictors. The highest is severity. The greater the depression severity, the possibility he may not respond. Severity, duration, suicidality, comorbid anxiety disorder, younger age, recurrent depression, female gender, insomnia, psychotic features, cardiovascular disease, male gender, substance use disorder, family members with depression, all these have been found to cause treatment resistant depression. That means more these factors, the more the chances of the patient becoming treatment resistant depression. Kataske and his colleagues published an important study in Acta Psychiatrica Scandinavica. The title of the study is Clinical Factors Predicting Treatment Resistant Depression, a affirmative results from European multicenter study. The results clearly again reported symptom severity, psychotic symptoms, suicidality, generalized anxiety symptoms, inpatient, higher number of antidepressant failed in the past, lifetime number of depressive episodes, longer the duration of the current episode, there is a possibility they may not respond. And now, a new prediction model for evaluating treatment-resistant depression was proposed in Journal of Clinical Psychiatry by the Kataske and his colleagues. This was published in Journal of Clinical Psychiatry. This study took an innovative model. They introduced something called as data pool of 400 patients to the computer. They applied machine learning. That means whether by writing an algorithm, by giving a set of data, whether the model will be able to predict who are those patients who do not respond. Here, the authors looked into various 48 clinical, sociodemographic, and psychosocial predictors for treatment outcome by various literature review. And they gave 400 patients data thoroughly, and also comprehensive data was given. And now the machine learning algorithm gave some results. Again, there is no bias here, although the bias may be because of writing of algorithm and how the machine learning occurred. But this study clearly said that the most useful predictors for treatment outcome were time span between the first and the last episode of depression, age at first antidepressant treatment was given, response to first antidepressant treatment, severity, suicidality, melancholia symptoms. That means if the patient has affective symptoms, then affective symptoms basically retardation, number of lifetime depressive episode, IP patient, comorbid medical conditions are considered as a predictors for treatment resistance. While single predictor could not reach a higher percentage, multiple factors should be considered to get the higher prediction for treatment resistant. The machine learning algorithm was able to have 65% prediction of treatment resistance and 77% of remission. That means if you consider multiple factors only, you'll be able to predict 65% in a patient whether he is going to develop or not. That means even now we do not have 100% model to say yes, these are the patients who are going to develop treatment resistant depression. The simple reason is depression is an heterogeneous condition having polygenics, genetics involved, and epigenetics. Further, the environment and stressors play a crucial role. Another important study by Rybak and his colleagues, published in Depression and Anxiety in 2021. The title of the study was Treatment Resistant Major Depressive Disorder, a Canadian expert consensus on definition and assessment. This Canadian expert consensus also looked into the predictors of treatment resistance. Again, those experts agreed if the symptom severity, number of episode, frequency and recurrence, longer duration of illness, current psychosocial stressor, number of lifetime episodes, bipolarity, current psychosocial stress are stressful life events. Further, comorbid anxiety disorder, psychotic features, personality disorder, substance use, comorbid medical condition. Treatment factors like number of previous antidepressant trial, number of augmentation agents, failed psychotherapy trial, all these were considered as factors which will be considered as a treatment resistant depression. More the number of factors, the more the chances he may not respond. Now, let's move into assessment of treatment resistant depression. First and the foremost, you need to rule out whether it is a pseudo resistance. That means if the patient has not received adequate dose, adequate duration, whether the patient has not adhered to the treatment, misdiagnosis, missing of comorbid diagnosis, relapse, it can be, recurrence, it can be, whether the patient is a rapid metabolizer of the medication, whether the patient is also taking some drugs along with this. So, hence, you need to consider pseudo resistance first. For this, you need to do a detailed evaluation, family history, look into the stressors, whether there is a family stressor, economical stressor, occupational stressor, interpersonal stressors. Check for adherence of medication. Ask whether there was a supervised medication, how many medicines were bought, how many medicine slips were left behind, what was the diagnosis. Check for whether there is any comorbid psychiatric condition, medical condition. Look for psychosocial stressors again and again. Optimize the dosage. Supervised medication should be given. Structured assessment to look into the comorbidity by using mini, SCID, or else WHO, FLY can be used. And for assessment of response, best would be Dutch measure for quantification of treatment resistant depression, because this is a comprehensive, dimensional, and up to 27 points will be given. You can also use Madras or CGI for quantification of symptoms. You can use any of these scales: Hamilton, Montgomery, quick inventory for depressive symptomatology, CGI, severity and improvement scale. Please do use Dutch scale for treatment response. Further, study by Halleris and his colleague published in 2021 gave an algorithm for treatment resistant depression. First, do clinical assessment. After that, do lab testing. The lab testing focuses on nutrition, especially iron deficiency, vitamin deficiency, thyroid deficiency, folate deficiency, and vitamin B12. Further, they also look into whether there is any inflammatory condition, autoimmune condition. And also, pharmacogenomics is done to look whether it is a rapid metabolizer or a slow metabolizer. The clinical assessment, as I mentioned, a comprehensive assessment is done. Look into various comorbid psychiatric condition, comorbid medical condition. Identify the stressor. Look for the stress. Whether the patient has received adequate dosage, duration, adherence has to be considered. And further, you need to now look into the diagnosis, medical and psychiatric diagnosis, comorbidity if it is there, treat them adequately. Further, you need to consider novel treatment if there is a treatment resistant depression. Now, if you look at the staging treatment resistance, as I mentioned earlier, Dutch measure for quantification is the best. However, some studies also have used Maudsley staging model. I would rather prefer Dutch measure for quantification of treatment resistant depression. Many practical benefits have been considered using staging of treatment resistance. Finally, my dear friends, operational definition of treatment resistance in the real world, especially in private practice or else in academic institution. The treatment resistance should be defined as non-response to two consecutive treatment with SSRI or any antidepressant with adequate dose and duration. That can be considered as a treatment-resistant depression. To conclude, treatment-resistant depression carries a high burden, not only to the patient, family, community, and also nation at large. Hence, we need to aggressively treat treatment resistant depression. However, there is a lack of consensus with regard to definition of treatment resistant depression. We need to consider real world studies, not in academic institution or else the institution like apex institutions. It has to be real world. We need to have a proper assessment methodology which can be done in real world, not only in the academic institution, and those kind of definitions should be used. So many studies have clearly said that there is no consensus. Hence, it is very difficult to do studies and compare across the world. Hence, my dear friends, now we need to come together, come up with a clear guideline. What is treatment resistance? How to assess treatment resistance? Number of antidepressant required? What is the dose? What is the duration? And what is the response? And we need to take a call whether brain stimulation and psychotherapy to be considered or not. These are very essential to understand treatment resistance. Thank you very much for giving your valuable time. Stay safe.